Good afternoon. I'm Professor Josep Llovet, Professor of Medicine at the Mount Sinai School of Medicine in New York and at the University of Barcelona. I'm going to talk today about evolution of treatment for advanced HCC. Here you have the outline of my presentation. I will briefly talk about molecular pathogenesis and drivers, management of advanced HCC, first, second lines and immunotherapies, and then finally the combination therapies with atezo, bevacizumab and beyond. This slide summarizes the incidence and mortality rates for HCC. Liver cancer is the sixth most common cancer globally, the fourth leading cause of cancer-related mortality. Most of the cases occur in Southeast Asia and Sub-Saharan Africa, and in Europe we have around 70,000 cases per year, and in the US around 40,000 cases. The incidence of HCC is increasing globally, and it is expected to reach 1 million cases by 2025. In terms of mutations, HCC shows a profile of medium number of mutations per tumor, around 60 to 70 mutations per tumor, far from the hypermutated tumors like non-small cell lung cancer and melanoma, and also far from the very low mutated tumors, mostly liquid tumors or pediatric tumors. We ran genome sequencing analysis including 250 patients and identified that TERT, beta-catenin, TP53 and ARID1 were the most prevalent mutations, and unfortunately all of them are undruggable. In a further meta-analysis including close than 1,000 patients, again in red we identified the most common mutations: TERT 55%, P53 27%, beta-catenin 26%, and so on, are undruggable. Conversely, in green, the druggable mutations have a low prevalence in HCC, BAGF signaling with BAGF amplification around 4-5%, FGF19 amplification 5-6%. Overall, 25% of HCCs have at least one druggable mutation. But in reality, this percentage falls in the area of quite undruggable tumors, considering all the spectrum of solid tumors, as you can see in this slide, where tumors like melanoma, GIST, and breast have more than 50% of the tumors with at least one druggable mutation. In real life, this study, conducted in Memorial Sloan Kettering Cancer Center in more than 10,000 patients, where the platform impact, including 500 genes, were tested in all tumors. This led to the fact that 37% of the patients were treated with molecular therapies, 45% of the patients with cholangiocarcinoma, but only 5% of the patients with HCC. This is a real-life platform. Let's talk a bit about the management of HCC in first and second line. This slide summarizes you the natural history of the disease. We have median survival for early stages 36 months, for intermediate without treatment 16 months, and for advanced 8 months. Then at early stages with resection, transplant, local ablation, we move the survival to 60 months, in intermediate to 26-30 months, and in advanced nowadays beyond 17 months. I will explain about that. And in terms of unmet needs, certainly adjuvant therapies after resection, local ablation are probably the number one clear unmet need in research. This is the trial design of the SHARP trial. We conducted this phase 3 trial comparing sorafenib versus placebo, and we stopped the trial at the first interim because we identified differences, 10.7 month median survival for sorafenib, 7.9 for placebo, hazard ratio 0.69, favoring sorafenib. And as a result of that, sorafenib in 2008 was considered the standard of care, first systemic therapy effective in this disease. In a further meta-analysis, including the SHARP and the Asia-Pacific trials, we identified that patients without metastases and patients with hepatitis C viral infection are the two prognostic and predictive factors of response to sorafenib, and certainly I'm showing here the survival curves of those patients with Hep C treated with sorafenib, 14-month median survival compared to close to 11 for the whole cohort. Conversely, in terms of Child-Pugh, certainly Child-Pugh A in sorafenib in real life 13.6 month median survival, but in Child B 5.2 and in Child C 2.6 months. After this trial, several trials has been conducted. I'm going to walk you through all these studies. In red, positive trials. In orange, positive for non-inferiority. And in green, positive for superiority. Lenvatinib is a multikinase inhibitor blocking FGF receptor 1 to 4, BSGF 1 to 3, and other kinases. Was compared head-to-head to sorafenib in a non-inferior mode and show median survival of 13.6 months compared to 12.3 months in sorafenib, has a ratio 0.92. The trial was considered positive for non-inferiority since the upper boundary of the 95% confidence interval was below 1.08. And in terms of subgroup analysis, lenvatinib was able to provide survival benefits similar to sorafenib in a subgroup of patients. In second line, the first drug approved was regorafenib, that is a modification of sorafenib. As you can see here, it includes only a fluorine group. And regorafenib was tested head-to-head to placebo in second line in patients that tolerate and progress to sorafenib. Trial was positive with median survival of 10.6 months versus 7.8 months for placebo, with an outstanding hazard ratio of 0.63. And again, the drug was effective in all subgroup of patients regarding FP status, macrovascular invasion, extrahepatic spread, and ECOG performance status. Another drug that was tested in second line with positive results was cabozantinib, a multikinase inhibitor, specifically blocking MET. And MET signaling is important because it's activated in 50% of HCC cases. Trial compared cabozantinib versus placebo, 10.2 months for cabozantinib, 8.0 for placebo, and the difference was statistically significant. So cabozantinib is now also accepted. In terms of subgroup analysis, particularly cabozantinib was useful in patients with extrahepatic spread and hepatitis B viral-related HCC. And finally, ramucirumab was tested in the REACH trial. It was a negative trial, but the subgroup analysis showed that the drug might work in patients with aggressive tumors characterized by AFP more than 400 nanograms milliliter. The REACH2 trial was designed, was positive, 8.5 months for ramu, 7.3 for placebo, and the meta-analysis shows that ramucirumab induces an increase of almost 3 months of survival, 8.1 months for ramu, 5 months for placebo in patients in second line with FP more than 400. Let's talk now about immunotherapy. The most common drugs tested are summarized in this slide: pembrolizumab and nivolumab as an anti-PD-1, atezo, avelumab, and durvalumab as an anti-PD-L1, and ipilimumab as an anti-CTLA-4. And here you have the landscape of approvals for these drugs that induce objective responses between 15 to 50% of the cases in most instances. In the CheckMate of 40, nivolumab was tested as a single agent. I'm showing here the data suggesting that certainly those patients with complete or partial response achieve an outstanding survival compared with patients with progressive disease, median survival 8.9, stable disease 16 months. Unfortunately, the main biomarker tested in these cases, PD-L1 status, did not identify patients responding to nivolumab. As a result of this, nivolumab was tested in frontline, head-to-head versus sorafenib in the CheckMate 459, and again 15% of the cases achieve objective response rate. Fortunately, despite that nivolumab lead to an outstanding median survival of 16.4 months compared to 14.7 months for sorafenib, these differences were not statistically significant and the trial was meant to be negative. Similar is the case of pembrolizumab that was tested in phase 3 compared to placebo in second line in patients progressing to sorafenib. Again, pembrolizumab induced 18.3% objective responses, but unfortunately the pre-specified p-value for superiority of 0.0174 was not achieved in this trial, with a median survival of pembrolizumab of 13.9 months compared to 10.6 months for placebo. So one of the questions on unmet needs is how we can identify, and in oncology mostly tumor mutational burden and PD-L1 expression are the biomarkers accepted. It seems that doesn't work in HCC, and in 2017 we described the immune class of HCC identifying 24% of the patients that we think that those patients have all the characteristics that might predict checkpoint inhibitors. And also on the other end, there is the immune excluded class that eventually may identify tumors with primary resistance to immune checkpoint inhibitors. To further support that, we recently published a study in transgenic animals where PD-L1 inhibitors achieve outstanding responses and survivals in animals with MYC-p53 transgenics. Conversely, the MYC beta-catenin transgenics that are beta-catenin mutations are enriched in the immune excluded class did not respond. Also, in this very small pilot study, those patients responding and progressing in this case to checkpoint inhibitors were those with an enrichment of beta-catenin on HCN1. Now let's talk about the new era in HCC management, the combination. We know that immunogenic tumors, or tumors that have an immunogenic microenvironment, respond to checkpoint inhibitors. These are called hot tumors. Whereas those that do not have this immunogenic microenvironment need additional drugs to enhance this microenvironment to achieve durable clinical benefits. These are cold tumors. How to transform cold tumors in hot tumors? One of the mechanisms is by using VEGF inhibitors that are able to decrease Tregs, decrease TAM and M2 macrophages, decrease MDSCs, and increase dendritic cells and maturation of these cells. Another mechanism to transform cold tumors in hot tumors is by using TKIs that are able to inhibit MAP kinase pathway, Wnt pathway, and then transform these tumors in hot tumors that are characterized by T-cell infiltration and increase tumor antigen presentation and other mechanisms. I'm going to now focus on this combination, bevacizumab blocking VEGF-A as ligand and atezolizumab blocking PD-L1. Tested in phase 3 and was published this year in New England Journal of Medicine. This is the trial design with the combination therapy in 501 patients compared 2-to-1 randomization versus sorafenib. The median survival for atezo-bev was not reached, and for sorafenib was 13.2 months. The hazard ratio was 0.58, and the trial was stopped at the first interim analysis due to this outstanding. Also, differences were observed in progression-free survival with a hazard ratio of 0.59. In terms of objective response, it was 27% by RECIST and 33% by modified RECIST for atezo-bev, and 12 and 13% for sorafenib, with these differences were statistically. Interestingly enough, patient-reported outcomes were assessed in this trial, and time to deterioration of quality of life for atezo-bev was 11.2 months compared to 3.6 months in sorafenib. Now that we know all these trials, here you have a final summary of treatments in front line and second line. The treatments in front line are compared with the standard sorafenib, and only atezo-bev is superior, whereas lenva in Orients show non-inferiority. Whereas in second line, rego, ramo, and cabozantinib are superior to placebo. So the strategy will be in second line we'll have atezo-bev in front line, but also sorafenib lenva can be used in front line in cases of contraindication for atezo-bev or presence of untreated varices and others. Then sorafenib and lenvatinib that have demonstrated to provide survival differences, and then rego, cabo, and ramo in those patients progressing to this line of therapy. Finally, I would like to close this presentation talking a bit about emerging combinations. I'm going to talk about the combo lenvatinib pembrolizumab, and then the combo cabozantinib ipilimumab and nivolumab triplet. In this study, including 104 patients, 100 of which were available for objective response, objective response rate was achieved with the combination of lenvatinib plus pembrolizumab in 41% and 46% of the cases, according to independent radiological review. And disease control rate was achieved in up to 88% of the patients. Accordingly, progression-free survival was 9.3 months, and overall survival was 22 months, which is a remarkable figure considering the scenario of beyond 17 months for atezo-bev. In terms of the phase 2, assessing the combination of nivolumab and ipilimumab, certainly the median survival for the first arm was 22.8 months, including 50 patients, but those patients that achieved objective response rate, the median survival was not reached, as opposed to patients achieving a stable disease. Median survival was 14.5 months. Again, this is another strategy with a triplet, nivo, ipi, and cabozantinib, and as you can see, median survival was 21.5 months, and not reached for the triplet, and progression-free survival was 6.8 months for the triplet. Certainly, regarding new agents, what we're seeing is that mostly those new agents are tested in combination with checkpoint inhibitors. That is now the hot issue. And we can see that these combinations and immunotherapies are applying all the trials, also in the adjuvant setting. I'm listing here 4 of the most remarkable trials in adjuvant setting, and 5 of these trials testing combination therapies with TACE compared with TACE alone. In advance, I'm listing here the strategies combining TKIs and IOs, combining IOs and IOs, and also one specific trial in China. So in conclusion, only 25% of molecular drivers in HCC are actionable, and unfortunately this information has not been impacting precision oncology in HCC so far. In terms of the evolution of treatments, certainly the most remarkable advance in this decade is the positive trial of atezolizumab plus bevacizumab that shows superiority compared to sorafenib and is now the first-line therapy. Other recommended therapies after progression to this first line is sorafenib and lenvatinib, and then rego, cabo, and ramucirumab. Nivolumab, pembrolizumab, and nivo-ipi have also been approved by FDA in the US based on phase 3 and phase 2 investigations, and phase 2 trials have not yet confirmed the benefit. And regarding emerging therapies in combination are currently tested in phase 2 and phase 3 and are tested in all stages of the disease, early, intermediate, and advanced, and certainly will change the management of the disease the next 5 years. Thank you very much for your attention.